Hi everyone, this is Shri. I'm one of the fourth year med students from Wake Forest, and today I'll be reviewing CT in neuroradiology. So for the scope of this talk, first we're going to do a technical review of CT and how it functions, and then we'll go into a deep dive of CT head, looking at topics such as indications for contrast administration, covering what windows are and how they're relevant to neurorads, and then integrating these windows into a search pattern that you can use to answer questions during preclinical or when you're looking at cases on the wards. While neuroradiology also typically reads CT neck and spine, for the sake of brevity, we'll discuss those in another video. Okay, so let's start with a brief technical review of how CT actually works. So imagine you order a head CT for a patient. As a patient passes through the scanner will emit X-rays that traverse the tissues of the patient's head. As the X-ray beams pass through these tissues, they will be differentially attenuated, typically corresponding to how dense the tissues are. On the other side, the beams will be collected by a detector, and this data will be forwarded to a computer that reformats an image where the more highly attenuating tissues appear brighter on the image. This is why we consider CT to be a measure of attenuation or density. And we measure this phenomenon using the Hounsfield unit scale. So if we look at this simplified scale on the right here, you see there are some commonly found tissues, their corresponding Hounsfield unit values, and how bright the tissues appear on CT. You can also see the same thing in the representative image on the bottom left here. Now, let's take a step back and think about why this is actually relevant to neuroradiology practice. Let's say I'm looking at this image and I don't know what the tissue composition of this region is. I can actually click on the image, see the Hounsfield unit value, and then compare the value to the scale here. So let's say the Hounsfield unit value for this region is 19. So I would then deduce that the region is made up of simple fluid, in this case, likely a CSF. Another example, so in neuro, attenuation or density of a finding is discussed relative to brain tissue. So let's say I see a lesion in this part of the brain here, and it's brighter than the surrounding tissue. I would describe that lesion as hyper-attenuating. On the other hand, if it's darker than the surrounding tissue, I would describe it as hypo-attenuating. And there are also iso-attenuating findings that appear about as bright as brain tissue should typically occur. This terminology is important to keep in mind as we move on to describe cases later on in the talk. Now that we have a basic understanding of how CT works, let's move on to talk about windows and how they're relevant to neuroradiology. I like to compare windows to filters on a picture. So let's say you take a picture, right? You can either modify it manually by adjusting parameters such as brightness and contrast, or you can just impose a preset filter on a picture to highlight specific qualities that you want to bring out. Along those same lines, we can put either preset windows on CT images to highlight specific features that would be helpful when we're looking for certain pathologies, or we can manually change the parameters of window width and window level. Let's look at this image here to see what these parameters actually are. So window level is defined as the midpoint of a window. Around this midpoint, window width is the range of Hounsfield unit values that are mapped to grayscale on an image. So if you have a wide window width, a lot of the image will be mapped to grayscale. And the inverse is true as well. If it's narrow, only a few points on the image will appear in grayscale. So let's look at this example where we have a window with a level of 50 and a width of 100. Areas below 0, Hounsfield units below 0 on the image will appear in black, and areas with Hounsfield unit above 100 will appear in white on the image, and everything in between will appear in grayscale. Now, this might be a little bit confusing if we're just talking about the parameters. Let's move on to actually look at a couple examples, and I think it'll make more sense. To drive the point home, let's look at a few examples of windows that we use commonly in neuroradiology. So I've listed 5 different windows here. the names, the width and level parameters, and what a CT would actually look like on that window. Now, when you open up a head CT in PACS, for example, you can either manually change these parameters to look at specific windows, or you can customize the window a little bit if you're looking for something niche, or you can choose from selected presets such as soft tissue, bone, brain, etc. Now, the name of the window typically gives away the type of pathology that you would look for on that window. So, for example, on soft tissue, we might look for scalp hematomas or lacerations. On bone, we might look for fractures. On brain window, we might look for pathologies that occur in the brain parenchyma, and then so on, with blood and subdural looking for bleeds in the brain, and then stroke looking for, obviously, strokes. You will have a better sense of this as we look through the search pattern later on in the talk. And hopefully by the end of this presentation, you'll have a better understanding of when to use specific windows to look for certain pathologies that you're suspecting. Now that we have a better understanding of windowing and when we can use specific windows to look for different pathologies on a CT scan, let's talk a little bit about contrast administration before we dive into some cases. So in reality, most CT head scans do not need to be ordered with contrast. There are a few very specific indications for which contrast is necessary, and we've listed those on this table here. Now, you might be wondering, what's the difference between arterial phase contrast or a CTA, venous phase contrast or a CTV, and a CT with contrast here? And to answer this question, let's think conceptually about how contrast travels through a patient. You administer the contrast intravenously. The contrast will go through the patient's circulatory system, their vena cava, their heart, their aorta, and because we're talking about CT head, from the aorta, we'll track the contrast as it goes through the patient's carotid and vertebral arteries and into the arterial system of the brain, the circle of Willis. Now, if you pause at this point and take a snapshot, a CT head scan at this point, as the contrast is traveling through the patient's arteries, that is what we consider to be arterial phase contrast. This typically occurs, depending on the patient's cardiac output, about 15 to 20 seconds after the administration of contrast. Now, if we flash forward a few more seconds and the contrast goes from the patient's arteries to the patient's venous sinuses, and we pause here and take a snapshot, this is what we would consider to be a CTV or a venous phase contrasted study. Now, if you further wait a couple minutes and the contrast perfuses into the patient's brain, this is what we consider to be a CT with contrast. And you really only need to order a CT with contrast for the indications shown here. And another important point to keep in mind is that most of the indications for CT with contrast can be better evaluated with an MRI study. Now, you would only consider using a CT if you're concerned about time, for example, because MRI scans take longer, or if the patient cannot tolerate MRI or cannot go in the MRI scanner for various reasons. Just something to keep in mind as you're ordering scans later on. Let's finally get into our search pattern and actually look at some cases. Now, the search pattern I like to use for CT head is I look through all of those windows that we looked at earlier, and in each window, I'm looking for specific types of pathology and specific findings. A couple important points to keep in mind before we start. We only have seen axial slices in a CT so far. Axial slices are where you have specific slices going from top to bottom, but you might also run into coronal and sagittal slices. Coronal is where you have slices going from front to back, and sagittal is going from left to right. So keep that in mind as we look through the various cases. The slices might look a little bit different depending on the orientation they're in. Another important point is that laterality on axial and coronal CT is flipped. So the left side of the image is actually the patient's right. So if I describe a finding on the patient's right, let's say I name a landmark on the right, you should be looking at the left side of the image. And finally, I won't really have time to review neuroanatomy. There are a couple really useful modules on case stacks that do a basic neuroanatomy review. If you think that'll be helpful before we get to some cases, feel free to pause at this point, take a look at those modules, and then come back and look at the cases afterwards. Let's start our search pattern by talking about the soft tissue window. As the name implies, this window is optimized to distinguish between layers of soft tissue, including muscle, fat, and skin. In the context of neuroradiology, this is typically used to assess the patient's scalp, the facial soft tissues, as well as the visible portions of the oropharynx and the neck, including the salivary glands and the orbits, for signs of trauma, foreign bodies, or masses. It's especially important to check for signs of asymmetry, both in terms of tissue thickness as well as in terms of attenuation. So let's take a look at some examples. If we look at the bottom left here, we see clear asymmetry between the right globe and the left globe. Compared to the left globe here, the right globe is deformed, and you can't see important structures such as a delineation between the posterior and anterior compartments or the lens, as you can clearly see in the left globe. Additionally, there's hyperattenuating fluid within the globe itself, which is suggestive of intraocular hemorrhage. So this person has likely had right globe trauma and rupture in addition to intraocular hemorrhage. If we move on and take a look at these two cases here, when you're assessing the scalp, it's important to just trace around the patient's calvarium. On the case at the top here, we see a clear asymmetrical prominence, likely corresponding to scalp contusion. If we look at the case in the bottom here, along the left side of the patient's skull, we see that there's a steep deformity here, as well as some foci of hypoattenuation posteriorly. This is likely corresponding to a scalp laceration. Additionally, you also have a region of hyperattenuation and scalp thickening here, likely corresponding to hematoma. Finally, this case is slightly self-explanatory, but you see a sagittal CT as well as a scout X-ray showing a nail embedded in the patient's eye. Soft tissue window is really good at delineating foreign bodies, especially metallic ones. Now let's move on to talk about our bone window. The bone window is optimized to check the bony structures in the air spaces for pathology. In the context of neuroradiology, it's specifically used to check the skull base and the calvarium for fractures or masses, and check the paranasal sinuses, the mastoid air cells, and the outer and middle ear canals for opacification or masses. Let's take a look at some of these examples. As always, it's important to look for asymmetry. So when evaluating this image here, compared to the right orbit, the left has a clear deformity along the inferior orbital bone. And as you can see, some of the contents of the globe, including the inferior rectus muscle, have herniated through this deformity into the patient's maxillary sinus. This is a good example of orbital floor fracture. If we look at this image here, there seems to be a clear multifocal trauma, likely corresponding to a comminuted fracture. And if you look at the 3D reformat, you get a better sense for how extensive the trauma actually is. Now, if we move on to the bottom, this patient has some opacification of their left paranasal sinuses, likely corresponding to sinusitis. And finally, this is a study ordered with contrast. So let's say this patient has a primary tumor and we suspect metastasis to their brain or the skull. This is an indication to administer contrast. And you can see along the left side of the patient's skull, there's a clear enhancing lesion, likely corresponding to a metastatic bone tumor. Enhancing is a terminology we use when something appears brighter after contrast administration. So we've covered soft tissues and bone. Let's move on to address how we actually look for pathology in the brain. The brain window is a good initial window that you can use to look for abnormalities in the cerebral and cerebellar hemisphere. hemispheres, such as asymmetry, areas of hyper or hypoattenuation, or mass effect and midline shift. You can also use this window to check the ventricles for enlargement, narrowing, or abnormal attenuation. Let's take a look at some of these examples, starting with the top left here. So if you compare the left to right cerebral hemisphere in this patient, you can see that the left cerebral hemisphere appears a lot more hypoattenuated compared to the right here. This is a good example of edema, and we'll cover the difference between vasogenic and cytotoxic edema in a separate video, but this case specifically is vasogenic edema. We're not sure exactly what's causing it. We can use MRI to better evaluate that. If we move on to look at the top right image, the cerebral hemispheres look okay. If we move down and look at the cerebellum, however, we see that there's an ill-defined mass in the right cerebellar hemisphere that's pushing into the fourth ventricle. This is a good example of a cerebellar lesion causing mass effect here. Let's move to the bottom row. So clearly this patient's ventricles look a little bit enlarged compared to the other examples we have. So not only do the lateral ventricles look bigger, but the third ventricle does as well. And additionally, you see areas of hypoattenuation lining the ventricles. This is what we call transependymal edema, and it's caused by high CSF pressure in the ventricles, causing CSF to actually leak into the tissues. This is a very dangerous sign because this patient is at high risk for herniation. This is obstructive hydrocephalus, likely caused by some kind of posterior fossa mass. If we move on to our last two examples, in this one, we can see along the left posterior hemisphere that there is some kind of cystic structure here with a central hypoattenuating region surrounded by a thin hyperattenuating membrane and some edema along the periphery. This can be either an abscess or potentially GBM, and MRI can be better used to evaluate. And finally, we see this patient has a hyperattenuating mass in the splenium of their corpus callosum with surrounding hypoattenuating edema. This is a trademark appearance of lymphoma, but again, MRI can be used to confirm. So we've talked about our three foundational windows, the soft tissue, bone, brain, and you should always use those windows when you're evaluating a head CT. We're going to move on and talk about a couple specialized windows that you can use when you suspect specific pathology, starting with stroke. So as you can see in this example of normal brain here, the stroke window is really good at highlighting the contrast between gray and white matter regions. This is important in the context of stroke because this differentiation is lost when a patient has an acute infarct. You should keep in mind in the acute setting that this is best diagnosed with MRI, specifically with diffusion imaging, but sometimes you'll see loss of gray-white matter differentiation in a non-contrast head CT, and it's important to pick it up when it occurs. Let's take a look at some of our examples. You'll see the same phenomenon in all four examples, just in different territories. So in this patient's left MCA territory here, they have loss of gray-white matter differentiation and a region of remaining hypoattenuation. And you can see the same findings in this patient's right ACA territory, this patient's left PCA territory, and this patient's left pica territory. Our next specialized window is our blood or subdural window, and this has high sensitivity for finding brain and meningeal bleeds. So let's talk a little bit about how blood products actually appear on non-contrast head CT before we look at these examples. In the hyperacute setting where bleeding might still be occurring, blood actually appears iso to hypoattenuating. As the blood clots and we move into the acute setting, the clotted blood appears hyperattenuating. And then in the next couple of weeks, as we move into the subacute to chronic setting, the blood products will appear isoattenuating and then eventually hypoattenuating. This is all due to the composition of hemoglobin and the degradation of hemoglobin over time. With that in mind, let's take a look at some of these examples, starting with the epidural hematoma here. Epidural hematomas typically have a trademark biconvex lens shape. And you can see this area of hyperattenuation in this example here. They look like this because they're confined to one suture space, and you typically see them along the frontal regions of the brain because they're caused by damage to the middle meningeal arteries. If we contrast that to the subdural hematoma, it appears much more crescent-shaped, and this is because it's not confined to one suture space. In this specific example, we actually see layering of blood products. So you can see this area of hypoattenuation looks very different from the posterior regions here, which are hyperattenuating. If this is taken in the acute context, this patient likely has active bleeding along the frontal region here and clotted blood posteriorly in this hyperattenuating region here. You can also see they have significant mass effect and midline shift pushing their brain inwards. If we move up and take a look at the subarachnoid hemorrhage, these typically spontaneously are caused by rupture of the saccular or berry aneurysm, and they cause this trademark appearance as they bleed into the cisterns of the brain of a 5-pointed star, which you can see here. And finally, intraparenchymal hemorrhage or interventricular hemorrhage just refer to any bleed that occurs in the brain parenchyma or extends into the ventricles, as you. And finally, let's look at some examples of the utility of CTA and CTV. As I mentioned before, the only distinction between these two is whether the CT is acquired as contrast is flowing through the patient's arteries or whether it's acquired when the contrast is flowing through the patient's dural-venous sinuses. And these studies are used to check for arterial or venous occlusion, respectively, or to check for vascular lesions and malformations. So with that in mind, let's take a look at some examples. This bottom left image is a CTA, and you can clearly see the patient's circle of Willis. If we trace their right MCA, there's a clear step off here, which is concerning for proximal MCA occlusion. This person likely has a large right MCA infarct. If we move on to the top case here, this is also a CTA. We can see the patient's basilar artery clearly, and as we approach the branch point, you can see there's a structure stemming from the branch point. This is an example of a saccular aneurysm. These typically occur at the branch points of high-flowing arteries. If we look at the case at the bottom here, you can see contrast is highlighting the dural venous sinuses. You can see a little bit of contrast in the superior sagittal sinus here, but there seems to be an area of hypoattenuation in the center. This is concerning for superior sagittal sinus thrombosis. And finally, this is another CTA study. This patient has a clear, large left-sided arteriovenous malformation. And you can see some phonitis of the malformation here. You can see some of the draining veins, as well as some of the arteries going into it. Those were all the cases we had for today. I hope the talk was helpful and I hope you learned something. I alluded to a couple specific pathologies in the talk, and we'll be creating more videos about those as we do a deeper dive into each of them specifically. If you're interested in neuro content, feel free to check those out.